Hello, we're presenting a video of a thoraco-lap repair of a right-sided Bochdalek hernia. A 45-year-old mentally retarded lady presented with an acute intestinal obstruction. She was transferred under our care after failed conservative management at a secondary center. On admission, she was diagnosed with a right-sided Bochdalek hernia with herniation of large amounts of the small bowel into the right hemithorax. The X-ray is suggestive of a right-sided diaphragmatic hernia with the small bowel part of the hernia sac, which is going into the right thorax. We performed a diagnostic laparoscopy and lifted the right liver. This diaphragmatic hernia defect was in the posterolateral position. The bowel was pulled into the abdominal cavity with gentle traction to whatever extent was possible. Once we got access through the hernia opening into the thorax, we put the scope in and we could see a collapsed right lung and large parts of the small bowel still in the right hemithorax. We attempted reduction of the small bowel, but it wasn't possible, so we switched over to a thoracoscopic approach. The patient's position was changed to a semi-prone position and access was made into the right thoracic cavity. Here you can see some parts of the small bowel still in the thoracic cavity, and they weren't getting reduced because of adhesions to the hernia sac. The adhesions to the hernia sac were taken down with a harmonic scalpel and monopolar coagulation. And once that was done, the small bowel was completely reduced into the peritoneal cavity. Due to the adhesions of the small bowel to the peritoneal sac, we had to take the peritoneal sac down and could preserve significant amounts of the peritoneal sac to aid with closure. We then began closure of the defect using number 1 Stratafix barb suture. As we were closing, the initial part was approximating well. However, as we moved upwards, the approximation of the muscle wasn't as good and the muscle was cutting through. It is at this point that we decided to use a pleural flap as a transposition flap to cover the defect over the muscles. The pleura was dissected of the vertebral column and of all the structures, taking care not to damage any vessels underlying, and it was then transposed over the defect to cover the muscle and ensure that the gaps in the muscle do not cause trouble. So here we can see the pleural flap being used to approximate the defect in the muscles that was created while suturing and cutting through of the muscle. And once this suturing was performed, the gap was completely closed. We then measured the defect and decided to place a composite mesh over the defect. This was done to ensure that there was no recurrence of this hernia and no blowout of the defect, especially considering the poor quality of musculature in this particular patient. An intercostal drainage tube was then placed under vision in the right hemithorax, and the patient was turned to the supine position and given positive pressure ventilation. A diagnostic laparoscopy was performed to check for adequacy of the repair, following which the patient was extubated and shifted to the ICU. This is a comparison of the pre and post-op x-rays. You can see that there's a partial expansion of lung. This was taken on post-operative day 2. The patient developed gastroparesis post-operatively, was placed on NJ feeds for 10 days. This resolved spontaneously and she was discharged on post-op day 10. The ICD was removed on post-op day 3 and she's doing well at her 1-year follow-up. Thank you for watching.